Morning, everyone. Thank you for bearing with us as we had some technical issues, but we are all now live. I am Oxides Barbeau, President and CEO of United Hospital Fund, and it is my pleasure to welcome you to the second in a series of convenings on implementing HR 1 and preserving health coverage in New York State. We have a record-breaking nearly 1,800 people that have registered for today. So for those of you that are new to UHF, we are an independent nonprofit dedicated to building an effective and equitable healthcare system for every New Yorker. We play a unique role in the New York health ecosystem as a think and do tank focused on high-level policy and on-the-ground innovation. Going all the way back to our founding in 1879, we've been bringing people together to talk about the most pressing issues in healthcare in New York, especially around facilitating and preserving access to care and health insurance coverage. So today is just the latest in a continuation of our longstanding collaboration with the state, facilitating discussions like this. Back in 23 and 24, we did a series of meetings around the public health emergency unwind that serve as a model for this HR 1 series. To remind you, our first meeting was in March, and it was to share all the planning that was put in motion based on what was known from the federal government about implementing HR 1. You'll remember that at that time, I invoked Donald Rumsfeld to remind us that there were still lots of known unknowns and that we could be sure there would also be unknown unknowns that we would need to contend with. And so guidance from the feds did come out earlier this month, but as is usually the case these days, there were curveballs to what we thought was already known, and you'll hear more about that today. And to borrow a basketball phrase, because I needed to find a way to say "Go Knicks," these unanticipated changes call for us to have a quote unquote read and react offense that emphasizes adaptability and coordination to leverage our collective willingness to come together as New Yorkers, working towards the same goal of maximizing the number of people covered and drawing from the collective strength of our wisdom and experience working with communities to help make smart design choices. So today you'll hear the latest from the core team that has been working day and night to ensure that we are ready to preserve coverage for New Yorkers. You'll also hear from a small sample of the many partners the state is collaborating with in preparation for January. What gives me the greatest hope as we enter the conversation today is that these meetings are great examples of the collaborative foundation that has been cultivated by our state partners and so many of you that are participating today. We're all talking, actively listening, and appropriately responding to the shifting landscape. So with that in mind, as we get into the discussion today, I ask that you listen intensely. Think about where you and organizations like yours can play an active role or supporting role in helping to keep New Yorkers covered, and that you ask the tough questions to kick the tires on what's being built. So a few necessary thank yous before we kick it off. I want to recognize up front the dedication of everyone working on this issue. I especially want to thank our partners at the state for all the work that they continue to do every day under extraordinarily challenging circumstances. Special thanks go to Jason Carey, Oscar Buitrago, Juan Maranon, and on the state communications team for working so closely with our team here at UHF on these meetings. I also want to thank the UHF team, Alessandra, Alexis, Chad, Erica, Giovanna, Joey, Camila, Peter, Sam, and Sharon. I also want to recognize the broad diversity of stakeholders joining us today, including funders, navigators, community-based organizations, providers, health plans, and advocates that are all vital to the success of keeping New Yorkers covered. And just a couple of logistics as we move into the program. We'll be fielding, or specifically Jason and his team will be fielding questions and comments throughout the meeting. So please use the Q&A feature at the bottom of your Zoom window for any substantive or technical questions and comments. The team will be monitoring in real time and will read questions to our speakers throughout the program. The meeting is being recorded, and both the recording and slides will be available on our website at uhfnyc.org in the coming weeks. Now it's my pleasure to turn it over to our state partners and introduce Amir Basiri, our indefatigable state Medicaid director. Over to you.
Thank you, Osiris, and good morning, everyone. Um, Thank you all for being here. Apologies for making this a virtual event, but as Osiris said, the Knicks did win championship, and for most people, this is the first time in their lifetime that they have seen that. But appreciate you all being here, echoing Osiris's comments on gratitude for our staff and the UHF staff for all the work that's gone into this, and then you all, of course, for being here and listening intently, as Osiris said. Um, I will be brief. We have a pretty packed agenda that will kick off with some of the updates that Osiris led with at the top, primarily the release of the interim final rule by the Center for Medicare and Medicaid Services on June 1st. That was the last day legally that they had to release this guidance and updated rules of engagement. And there have been a number of changes, some good, some bad, and we'll get into that. Gabby and I will go into that, and then we have a packed agenda thereafter. So if we want to go to the next slide, just to recap, it has been a few months since we last convened. In our last meeting, we gave you an overview of what we knew at the time, which was the HR1 statute and informal guidance that we had received from CMS. We talked about what we envisioned for our data strategy and leveraging existing and new data sources for income verification, how we envision our sister network being core to our coverage retention and support network strategy. And then Jason and the team talked a lot about how we're planning to communicate at a high level with consumers, plans, and our partners. Fast forward to today, we're going to spend a lot of time talking about the requirements under the guise of the June 1st interim final rule. We will expand on our data strategy and the new technology we have in place for income verification, and there's a nice demo on that. Gabby and our eligibility team will provide a comprehensive update on work we're doing with our local districts of social services and primarily the Human Resource Administration in New York City to ensure coverage attention for our non-Magi ACA expansion population. And then Jason and the team will give an update on where we are with communications and how we're working with our partners. So going to the next slide. Another recap, just to reiterate what we shared with you a few months ago and our ongoing unwavering commitment to New Yorkers is that our primary goals with respect to implementing HR1 requirements and work and community engagement requirements is to limit coverage loss amongst eligible individuals, minimize the fiscal impact as well as the administrative burden for both members and healthcare providers and plans. We intend to do that by maximizing ex parte enrollment verification using existing and new data sources. We have a very large outreach and stakeholder engagement strategy that Jason and the communications team will go through. And we really want to build on what works and our core foundation, which with respect to Medicaid and Medicaid eligibility is the assister network. And what we have built there is unique. We intend to double down on the assister network to comply with these new federal requirements. So nothing has changed with respect to our commitment. Next slide. So the big updates from the June 1st interim final rule. And a lot of what we're sharing here is our interpretation of that. And we've been spending a lot of time going through the fine print. Some of us were at the National Association for Medicaid Directors summer meeting where CMS was in attendance and expounded on some implementation details regarding these changes. So we have sort of six buckets for things that we thought would be helpful to highlight for New Yorkers. One is community engagement activities are broader and more clearly defined under this rule. It specifies the type of unpaid work, in-kind work, some clarification on how a community service engagement can meet the requirements, and additional guidance on education and work programs, as well as caregiver activities. These are things that we had alluded to or mentioned in the last meeting that we thought would occur. They have been clarified and confirmed and more clearly defined. Nothing major new, but Gabby will go through the details in a few slides with respect to the changes. Another thing we had assumed and is now confirmed is that income can be used to demonstrate compliance. That is specific to the 580 gross monthly income exemption requirement that would be a condition of meeting the work requirements. That's something we assumed. It's great that it's now confirmed and in place, and we'll talk a little bit more about how that will factor in. One big change, we had assumed previously when we met that we could choose one or many of the available short-term exemption options. And all of this will be clarified in subsequent slides, but we are not able, the interim final rule clarified that we are not able to select one or two. It's an all or nothing approach, meaning we would have to adopt all short-term hardship exemptions, the operational considerations and administrative complexities of maintaining those exemptions, whether or not they are applicable for our population. And we are currently assuming that we will be applying for all short-term hardship exemptions, but there's still some details that I think we would like to know from CMS from an operationalizing standpoint that Gabby will discuss. Next slide. So now a little bit more of the larger changes as compared to both the HR 1 legislation and informal guidance we received from CMS prior to June 1st. So medical frailty includes the largest change as compared to the initial legislation. CMS has narrowed the scope of what can be considered medical frailty, how states confirm and document medical frailty, and some details as to how we have to maintain auditable, verifiable list, codes, screening processes, because self-attestation will be limited. There will be re-verification requirements. We have been spending a lot of time thinking about this, and while there's a tremendous number of changes, we think we have a very good go-forward approach that will both protect members and the state from future audit risk and compliance risk. All states are grappling with some of the medical frailty changes that have been outlined. What we have been hearing from those states as well as CMS is that the approaches we're taking are compliant as well as consistent with what other states are doing. And we will get into that in a few slides. But significant changes here, very prescriptive, much more restrictive than had been originally envisioned in the legislation. The verification requirements are also more prescriptive. They're a little wonky with respect to how it will work starting in January 1st of 27, as compared to what we maybe have to do starting January 1st of 2028. But we are and are being encouraged to rely on automatic verification whenever possible, which is good. That's something we've been planning for and would like to leverage. However, in 2028, there will be the requirement that we have documentation in the event electronic data is unavailable for both new and existing members who are subject to this requirement. Last piece before I turn it to Gabby for some further details is the notice and outreach requirements have been expanded. We have to provide additional documents for consumers to notify them when exemptions begin or end, uh, depending on where they live, if that hardship exemption applies, and more additional modalities than just a notice in the mail or a text message or email. So we are working to put those parameters in place and ensure that we can comply with the new rules. That is a very high level, and now I will turn it to Gabby and we'll go through piece by piece.
Thanks, Amir. Okay, so the first thing we're going to touch on is what we mentioned with the $580 for an exemption, which is basically the federal minimum wage of $7.25 times 80 hours. So if an individual meets that, they're exempt. I think one thing in the rule that we were originally told was not going to happen, but is in the rule, the interim final rule, is you can kind of extrapolate on, so say for example, you have $480. You can determine that that would have been 66 hours and that you need 14 more hours to be compliant. So that would show you that, okay, I could try to go do community service for 14 more hours to be compliant. So I think that's a flexibility that we like and we were not expecting. Also, as Amir had mentioned, you can use in-kind hours to help meet these exemptions. And again, this can all be a combination of community service, education, and work to meet the 80 hours to meet the exemption.
And just to add to what Gabby's saying, we had mentioned this before. This is by far and away the most important aspect of our ability to keep New Yorkers covered. We should be grateful we have a high minimum wage as compared to the federal standard. We believe this will be the most impactful exemption, well beyond any of the others we'll talk about later today. And I know everyone is super interested and focused on medical frailty. Just want to mention that this exemption will be the most impactful way to keep people covered. So what Gabby expounded on is really option C. You know, if a household, anyone in the household has gross income of 580 in that given month, the entire family will be considered eligible and can maintain their Medicaid. If they've done 80 hours of work that either does or does not exceed the 580, they will be able to keep their Medicaid. And then the new change that was welcome news in the IFR is that we can use both to convert and meet that requirement. So this is really the most important exemption with respect to implementation and will continue to be.
Next slide. So just to touch on the timing. So a new applicant applying on January 1st that is in the expanded category, our Group 8 category, would have to demonstrate compliance the month before application. So I think that is what we've, been operating on all along. We have received clarification prior to the IFR, but also in the IFR for existing members. They would have to demonstrate, we would begin the community engagement requirements for anyone due to renew March 1st, 27 and forward. So your January and February renewals would not be subject to community engagement requirements. Next slide. So again, this is the list of the exemptions. So again, as Amir mentioned, we think this 580 is going to be our biggest group, right? But we also feel like we're going to have a large percentage of individuals that have a child under age 13 that will be exempt. We did receive some additional clarification on certain certain exemptions, such as a veteran with a total disability. But this is the whole list of, who could potentially be exempt. And I think it's largely unchanged from what we were originally told.
Yes, these are relatively prescriptive in the law. Gabby, before you go on, I see a question in the chat I think you can answer.
Okay.
And it relates back to the prior slide. And the question I will read for everyone's awareness is, so the household income that at least one person in the house is required to make is $580 per month, so everyone can stay on Medicaid. Is that right, or is it at the individual level?
So if there are two individuals in the household, yes, only one has to meet the requirement.
What if there are three?
If there are three, I haven't thought about if there are three. I'm thinking of the parents.
It is intended to apply at the household level.
Yeah.
Which is a good clarification the federal government had in the IFR. It is more favorable for households with multiple family members on Medicaid.
Next slide. So again, Amir mentioned this at the beginning. There are 4 short-term hardships in the IFR and in the law that we thought we could pick and choose and decide, which ones we would want to try to take up. The IFR clarified that it would have to be all 4. So we are pursuing all 4, but I want to kind of just go through them and mention some of the additional complication that I think this brings. So the first is if the area is a high unemployment area, which would be unemployment over 8% or 1.5% of the national unemployment rate. So New York definitely has, some big counties that potentially would meet this requirement. We would need to ask CMS for, approval to use this exemption. And this, we would need to document to them that we've met the parameters to be qualified for the exemption. The same applies to a federally declared emergency or disaster area. So that would be, a presidential declared disaster area. And that changes, frequently with different things going on. We would also need to request CMS approval to be able to use that disaster. The next is someone who is hospitalized or, in an acute facility. And I think the last one is the one that we are really trying to think through how we could operationalize it. If someone is out of the area for an extended period of time for medical treatment that they cannot get where they are at home. So another complication that I think we weren't expecting is we need to inform people when these short-term exemptions end. And I think we have to, we're thinking through that because some of them, we might not know when it would end. Yeah. So we have to let them know, we have to notice them when it would begin and when it would end, which, again, we have to figure out how to operationalize all of this, but we are pursuing all 4. there's anything else you want to add on that.
Yeah, just to add, I mean, it sounds simple. This is actually incredibly complex, and particularly on that noticing point. So for the to the points Gabby made, just keeping in mind high unemployment area, unemployment data is not collected by the Department of Health. It's reported elsewhere. We would be using those other data sources, but we don't actually know when those data sources or when that condition would no longer be met. We want to make sure people have the correct information at the right time. And it starts to get complicated with notices and timeliness, but we are intending to pursue all hardship exemptions. How impactful they will be is unclear. Next slide.
So as Amir mentioned, this is one area that I think was much more restrictive than we expected it to be. Not only do you have to be determined medically frail, but your disability or your issue needs to be to the point that it makes you unable to meet the requirements, right? So your disability has to be so severe that you're not able to meet these community engagement requirements, which again is more restrictive than we were expecting. So these are the big categories, and we have done, I will say, a tremendous amount of work to try to map out, how we can identify individuals through claims data who meet the requirements. We've worked extensively with our medical directors, and our data systems group has been just a huge help with this. But I think, CMS has now pointed to having like a set of like codes that we can go back to show how we're defining medical frailty. They have pointed to certain states that they find acceptable, and we're kind of comparing the work we've done against those codes to see how similar we are, which I think we are fairly similar, I would say. So go.
Yeah, and to Gabby's point, we have been talking to a lot of states and getting the details of their approach. In addition to what she said, Louisiana has been sort of one leading the charge here, working not just with other states, but with CMS on developing that underlying methodology and code set. We are going to align with that underlying methodology and code set because it is deemed compliant thus far by CMS, and it is practically the same as the code set we had developed initially and captures a lot of those populations. So we have been working with them to better nuance that. But I just want to reiterate, there's a lot of talk on medical frailty, and we can't let medical frailty, we're not implementing medical frailty exemptions. We're implementing work and community engagement requirements and other HR1 requirements. Medical frailty should apply to 30–40% of the impacted population. That's what every other state is showing. So we know that that is the range that we'll likely be in, meaning there's still 60% of people that will not meet these exemptions, and that we need to ensure we have programmatic and operational supports in place because they very likely will meet the work and community engagement requirements for another reason. So more to come on this, but I think we were disappointed, but we think there's still a silver lining with respect to implementation.
And just, one other thing that I forgot to mention. So we need to rely on, screening tools, codes, and we have to limit self-attestation. We need to document whenever we can't verify something. So that is, another thing that we're going to be relying on, and I think is a guiding kind of principle throughout the reg, that we need to try to, use our data first, but if we can't, we need to document, and, that will be something that we are building into our processes. Next slide.
I can take this one, yeah. So just to recap some of the policy decisions that have been made thus far and where we are right now with respect to implementation is we are implementing and planning to implement work requirements on January 1st of 2027. We are planning to only verify compliance or exemption at an individual's renewal application. So we would not be conducting work requirement or community engagement verification more frequently than the 6-month renewal timeline. Some states will be doing it whether or not they apply it on a monthly basis. That is not the approach New York is taking. We will also be transitioning members to the 6-month renewal process after their first renewal, regardless of when it is in the calendar year 2027. So for example, people renewing in February of 2027 will have their subsequent renewal in August of 2027. We will only require 1 month of community engagement compliance for each application. Though the law allows you to require up to 3 months, we are choosing 1 month in the best interest of members, that being the most recent month to their application or renewal. As we mentioned earlier, we're intending to pursue all hardship exemptions at this time. And we are not intending to request a good faith implementation exception, primarily because the IFR explicitly states that only 2 states will receive them, and we believe one is going to be Alaska. So those are some of the decisions thus far. I know there are some questions. I think we're done with this section. Let us move to delinking, Gabby.
Next slide. So one thing we thought it was important to touch on, because it's connected to this effort, is delinking Medicaid and temporary assistance. So just at a high level, our rules have really grown apart over the years with the Affordable Care Act. Things are not aligned as they used to be. And again, we are relying on a lot of automation and trying to build in ex parte renewal and new data sources in our modern eligibility systems that we would not be able to do in the world of WMS. And the local districts, honestly, to have to implement 6-month renewals when, with their staffing limitations, I think sometimes struggle to do the annual renewal in a timely manner. So these were some of the reasons why, it became apparent that this is time to do this. Next slide. So we've been really doing a lot of work with our colleagues at the Office of Temporary and Disability Assistance to operationalize this. Starting in January, any new applicant for temporary assistance will no longer be enrolled automatically in Medicaid. They will need to specifically apply to get Medicaid. So it will be a big focus of ours to try to make sure individuals know what they need to do to apply for Medicaid and have as many channels open to them as possible so they can maintain their coverage. By doing this, again, when someone enrolls through whichever system, they would be eligible for it, because it's not only going to be New York State of Health. Some individuals will be enrolling in our new Medicaid eligibility client management system, and some will have to remain with the local district at this point because the services they need are not available yet through enrolling in MECM. So there will be, 3 different paths of people to get enrolled in Medicaid. We've done a lot of work on, what needs to happen in order to do this. So we've been looking at notice language with OTDA. changing applications, and working through what kind of tools people need and the different pathways to make sure individuals know that they need to separately apply for Medicaid. Next slide. So these are a few of the tools that we've developed. Obviously, our Stay Connected website that I think Jason will get into a little bit more will have information available about this. We've developed a flyer, which we will distribute to assisters, and that OTDA will also distribute to individuals so they know, a consumer knows this is how they apply for Medicaid. We also have, people are probably familiar with our books 1, 2, and 3 with information about social service programs. We are removing Medicaid from those programs and have a new book 4 about what you should know about Medicaid, which we had already been working on. So this kind of helped push us over the finish line with that. Next slide. So again, we're working on materials not only for consumers, but for various types of, staff, our local district staff, so they know where to send people if they can't help them. Our customer service center, because individuals will be able to apply on the phone through the customer service center. And our network of assisters will receive training on this. We're working on workflows and kind of changes. A few things that we're thinking about, like should we have assisters co-located at a local district if someone had gone into their TA worker to apply, that they could just send them right to somebody without losing them before they leave. I think that is something that OTDA is really interested in. We are about to send out like a little survey that we are going to ask local districts if they already have individuals that are co-located with them, as well as asking assisters if they already have sites at any local districts. I think the other thing that we're looking at is, does OTDA, their eligibility workers, are they interested in getting trained to be an assister if they want to help someone? As well as any other local district workers, which we have already kind of put that option out there. Next slide. So again, starting January 1st, there are 2 different doors. You have to apply for TA, you have to apply for Medicaid separately, and it depends on, there will be a screener that directs you to the right place, depending on your individual circumstances. And one other thing that I just want to say, one thing we looked at was how individuals on TA, are they known to, say, New York State of Health? And we found that a huge number of individuals on TA, I can't remember the percentage, but have been on New York State of Health and then cycled off when they're TA. They might have lost TA and got back on TA, so they're cycling back and forth. So it is not something that we think will be unfamiliar.
It also explains why we need to make these changes before we implement to ensure that they can keep their coverage that they should, they are eligible.
Next slide. So one of the other big things that we're working on is how we transition the existing membership. We're working on, we think in rest of state, it'll be in 2 big scoops up of people before the renewal. So they can take advantage of renewing through New York State of Health or MECM, taking advantage again of the automation that we have and the ex parte renewal, which we're required to do, which we would not be able to do through WMS. New York City will be a little different, and we're still working out those details, but we will share those as soon as we have. So this is a huge undertaking on top of everything else we're already doing, but we feel like it's critically important so we don't lose these these people when it's time, when they're subject to community engagement requirements. So a lot of our focus at the end of the year will be on training and testing to make sure things are working properly. Okay. Next slide. I think that was it.
Yeah. And Gabby, I think you mentioned this for the applicants with TA who may require long-term services and supports or who may be Medicare eligible. Are they going to remain with the LDSS or?
Yes. Yes.
So yes, they will. Most people will be going to the New York State of Health. Those that require continuity of care for those long-term services and supports will remain with the district.
Okay. I think we will now flip over to the essential plan update. Danielle Holohan, Executive Director.
Just want
Take
to
it
make
away.
sure we weren't taking more questions. Hi, all. So I'm going to provide a brief update on where we are with the essential plan. We can flip to the next slide. One of the first impacts of HR 1 in New York. So just by way of reminder, we currently, the essential plan is offering comprehensive affordable coverage to 1.7 million New Yorkers. We started the essential plan under the Basic Health Program Authority back in 2015. It's an alternative to qualified health plan coverage, and it was under Section 1331, the Basic Health Program. At the time, and eligibility was limited up to 200% of poverty. In April of 2024, we were able to expand eligibility for the essential plan under a 1332 state innovation waiver. This allowed us to cover another 450,000 New Yorkers, saving them on average $6,000 a year. And again, essential plan coverage is an alternative to qualified health plan coverage. And it has been a very successful program in New York. We went on to amend the 1332 waiver in January 2025. We began offering cost-sharing subsidies for consumers in the qualified health plan market, and that enabled us to help another 6,000 New Yorkers to lower their deductibles and out-of-pocket costs at the point of service. So that's, a brief overview of where the essential plan has been over the years. Before I move to the HR 1 impacts, so we can go to the next slide. So as we've talked about a lot, unfortunately, HR 1 had some very drastic impacts on the essential plan program. And again, because the essential plan is an alternative to QHP coverage, the funding is tied to qualified health plan coverage, and specifically the premium tax credits that go to lower the cost for low-income consumers in the qualified health plan market. HR 1 drastically narrowed eligibility for lawfully present immigrants, and that really impacted the essential plan funding. So effectively, it cut our funding in half, about a $7.5 billion cut on an annual basis. So it made the operation of the essential plan as structured unsustainable. So that is what led us in October of 2025 to request to terminate the 1332 waiver and return the program to the basic health program. So this was approved in March. I think we might have shared that at the last convening here, effective July 1. So what CMS did was they approved the termination of the 1332 waiver and recertified our basic health program, which is governed by a basic health program blueprint, and that we are reverting right back to the basic health program as it looked before we went into the waiver in 2024. And importantly, with that recertification of our blueprint, we unsuspended the BHP Trust Fund, which is at about $9 billion. So that enables us, even though our funding is coming down significantly, we can leverage the trust fund as well to continue operating the program. The next slide, we talk about this transition to the BHP. It's been a very busy year. The key and the good news in this is that we are able to protect and preserve coverage for 1.3 million consumers who have incomes up to the BHP limit of 200% of poverty. So that's that population, nothing is changing for them. Unfortunately, for the population that we were only able to cover through the waiver authority, the 450,000 consumers with incomes between 200 and 250% of poverty, effective July 1, their essential plan eligibility ends. So on April 1st, we began this transition. We sent notices to 90 days prior to the change in eligibility to this cohort, letting them know that they will no longer be eligible for the essential plan because of changes in federal rules. Clearly, this is all because of federal HR 1. Not a change we take lightly, but unfortunately the reality. So that was the first step. A couple of points that I want to make, though. We have been able to preserve coverage for anybody enrolled in the essential plan who is pregnant with a due date before the end of the year. So they're staying covered. They're either retaining essential plan at a different level or moving to Medicaid. The DACA population will be impacted. They will either move to Medicaid if their eligibility is up to Medicaid levels, but unfortunately another change in HR 1. Those with incomes above Medicaid levels will no longer be eligible for any subsidized coverage come July 1st. So those are a few of the moving parts on this transition. The next slide is a timeline of the various steps and all of the notification that we have been doing out of New York State of Health. So again, I mentioned the April 1 notices that went out to 450,000 consumers. Again, that notified them of change in their eligibility effective July 1. May 4th, we sent renewal notices. So we reran everybody's eligibility and sent them notices on May 4th, letting them know what they are newly eligible for. So some individuals had a change in income since the last time we checked their eligibility and are remaining eligible for either the essential plan at a different level or Medicaid. But most of this cohort were told that they are now eligible for qualified health plan coverage. Then May 16th, the next key deadline is when the special enrollment period window opened. So that was the first day consumers could begin taking action to pick a new plan and enroll in new coverage. The next date following that, open enroll or special enrollment period window opening, we started messaging consumers through our email and text message campaigns so that it was clearer messaging, targeted messaging, letting them know about the changes and how we could help them. That's also when our enrollment assister outreach began. So we are actively engaging with this population. And I will say our call center has been very busy since these notices went out. But through the navigators and the call center, we're helping consumers navigate this change. The next key date is June 30th. That's the last day of essential plan coverage for the impacted consumers. July 1st, the date these coverage changes take effect. And then August 30th is the end of the special enrollment period window. So consumers can have all the way until the end of August to act, and there will not be a gap in coverage. So they can, that's how SEP rules work. They can come in and their coverage will go retro back to July 1st. So there's no gap in coverage. So those are the key dates. The last slide I just want to walk through is how we have been providing wraparound support for New Yorkers. We have trained the enrollment assisters. They're a very key outlet for engagement with consumers on this transition, and we have provided them with detailed reports about the consumers with whom they've worked that are impacted here so that they can conduct targeted outreach and help them find new coverage. As I mentioned, our call center has been very busy since these notices have gone out helping consumers. And we are tracking enrollment as consumers navigate this change. It's too early to report numbers, but we are tracking where these consumers go, as I mentioned, and we're hearing from our plan partners. Many consumers are staying at other levels of coverage through the marketplace. And as this settles out, we'll know more and be able to share where we see consumers going. And then a couple more points to end this with. I've mentioned some of the communication channels already. Email and text is a very important channel for us to communicate with our consumers, making sure they're aware of these changes, why they're happening. We continue to update our Stay Connected website. That is where we post all information about essential plan and the transitions. And then we have a few fact sheets that we've put out. The first one is on free and low cost healthcare resources in the community, New York City, and rest of state, because we know unfortunately that there will be some consumers who become uninsured as a result of this change. And then finally, we put out a fact sheet on continuity of care protections for consumers moving to other coverage. So that is also on our website, and these are linked. So when these slides get shared, it'll take you directly to those pages. So that's a quick overview of what has been happening on the essential plan. And I'll just say, you know, these changes, again, driven by federal law. We're doing what we can to ensure the transition is as smooth as possible for consumers. And as with everything HR1 related, we're committed to keeping coverage for as many consumers as possible and smoothing this transition however possible. So I think that's it on the essential plan.
Okay.
Thank you.
Thank you. I think we can, do we want to do a couple questions from the chat? We do have some questions in the chat. So why don't I pick a couple and see what we can do.
Are we doing Medicaid and essential plan?
Why don't we do a few on essential plan, and then we'll go back to Medicaid. So on essential plan, we have a question here. Are they going to continue to allow consumers to enroll in EP 200 to 250 until the end of this month? Will we still get that eligibility?
We are currently, currently people are still able to enroll in EP 200, 250. We're continuing to monitor how that enrollment is increasing, and we're still in the process of figuring out how to manage that enrollment through the end of the month.
Okay. Other questions? I think that was one of the bigger questions on essential plan. Let's switch over to Medicaid. Hi, will there be an update on undocumented folks 65 plus who are on Medicaid? I saw that New York State will switch them to FFS Medicaid in the budget, but it would be helpful to know if the program will continue allow new people to enroll.
Thank you for that question. There are no changes to that program outside of it being administered in fee-for-service. People can still enroll if they're eligible.
It looks like we have another question on, can you explain how DOH will be implementing Medicaid work requirements for TANF recipients who New York has determined to be exempt from the TANF work requirements, following the information that CMS has determined that New York's TANF recipients are applicable individuals?
We are still looking at that right now. So we will keep you posted on that.
Okay. Another question, will the delinking apply to dual eligibles who apply for Medicaid and TA via HRA or LDSS?
And we're delinking everyone. But there will still be people that have their coverage through a local district. But the whole program, we're delinking entirely.
How about for TA applicants who are 65 plus, will they remain at the LDSS?
Yes. And if they're not eligible to enroll in MECM at this point. So if they have the long-term services and supports.
Yeah. That is a
Eventually.
very, very small percentage of who we're talking about being subject to the delinking, but yes.
Sorry, just scrolling. So there is a question about, and this might be for you, Gabby, around individuals getting notices about their continuous coverage ending by July 1. I'm not sure if they're talking about Medicaid or essential plan. I think Danielle just walked through the essential plan answer. Do we have information to share on Medicaid for those individuals?
So we have put out, I believe, a gist on this for the Medicaid side, or it might be in final clearance. But yes, we will be noticing people. We can't continue to have 12 months continuous coverage for adults when we have 6-month renewals under community engagement. And we also had to end our 0 to 6 continuous, and we have issued guidance on both of those, I know for a fact, on the children. And I believe in our webinar yesterday for the assister community, we did address both of those pieces in our training, which I think should probably already be posted.
Yeah. It
It'll be
should,
posted today, yeah.
yeah, the changes Gabby is referencing, just to be clear, are directly a result of federal legislation changing under HR 1. So that is why those changes are being made, or those notices are being received.
Can you, we've gotten a number of questions about the 580 and how
Yeah.
that works. Do you think you can just explain one more time how we're interpreting the rule on the 580?
Yes, and I think I saw some of the questions. So there are 3 ways to meet the 80-hour requirement. One way is for an individual to demonstrate that they have earned $580 of gross income, which is being treated as an exemption to meet the requirement. That's the first step. The second is to do the 80 hours or show that you worked or had community engagement or educational activities of 80 hours. And then the third is a combination of income and hours. So it's more flexible than it had originally been envisioned. And then on top, so that's just for an individual. Those are the 3 ways they would be able to demonstrate. For households, it's also favorable from our perspective in that only one individual within the household has to meet the requirement. That may be the only person subject to the requirement. If you have kids or dependents that are exempt. But if you had one working parent and one non-working parent in the same household, and the working parent had the $580 of gross monthly income, both parents would be treated as exempt, even though only one is meeting that requirement. I hope that helps. Gabby, anything you want to clarify?
Nope, and the 580, as we said, it comes from $7.25, which is the federal minimum wage. And obviously in New York, the minimum wage is much, much higher than that. So we times 80 hours. So we really expect that this will be our biggest exemption. And I think being able to convert how many hours you're short to make up the difference was a positive thing that we're going to be working to operationalize that.
Great, thank you both. We have a lot of questions. I think we're going to be able to take about 2 more, and then we'll work on following up on what we can't answer. I think there are a lot of questions around detailed questions around medical frailty. I don't think we're prepared to answer those, but we'll take those back. There have been a few questions around parents. So here's one. Will parents of children over age 13 be subject to 6-month renewals, the statute indicates that provision only applies to the expansion population, but work requirements must be verified every 6 months. Is that something we're prepared to answer today?
Yeah, I mean, we do have, I think we will want to respond to this in writing just to be crystal clear. There are parents in the adult group, there's a small cohort of them. We have some other eligibility uh, rules and logic that will ensure that parents remain covered. But let us get back to you in writing on this one just to be very clear about the nuance between the work requirements, the 6-month renewal, and any other HR1 eligibility changes that likely apply to this population.
And I will just add, one thing that we are really going to try to be doing is documenting things. We have some help in doing that. So we have everything out there to be transparent on how things are working. So, as we finalize decisions and make decisions, not only will we be doing training, but we will have documentation out there so everyone is clear on, how we're moving forward with implementation.
Yes, and that was another question we got. So thank you for answering that. I think you already answered the question around, can two different individuals' hours work income combine to meet the threshold, or is it only one person that can meet the hours for the whole household?
So I'm gonna, yeah, and Gabby, correct me if I'm wrong, but it is not that it's actually one person meeting the requirement is what exempts the household. We are not combining income or hours of community service or hours of educational advancement amongst household individuals and combining them together to meet the requirement. That is not permitted. However, if one person, in all likelihood, the head of the household, is able to meet the requirement, then the entirety of the household has met the requirement with respect to Medicaid eligibility.
Great, thank you. And we've gotten a lot of questions about, how the unemployment hardship exemption would work, which counties it would apply to. I think on that, again, I don't think we've come to a conclusion on how those would apply yet, but we will follow up with that information. We've gotten some questions around the impacts and our estimated volumes. Again, this rule came out a couple of weeks ago, so I think we're still assessing. I think we need to understand better how we're going to implement different provisions before we're able to sort of reasonably estimate volume. So I think I'll stop there, but we do have all the questions everyone has asked, and we will do our best to follow up and answer what we can when we can.
Sounds good. So we are about halfway through the presentation. We want to just take a 10-minute break so we can regroup and get reset for the next section. So why don't we come back here at 12:35? Okay. So we will be back here in 10 minutes and we will get started with our second half of the presentation. Thank you. Okay, we are back. We're back. Thank you everyone for staying with us. We are going to move into the second half of the presentation. And to kick us off and kind of following a lot of the questions in the chat, we're going to talk about income verification in New York State of Health. So I'll pass it off to Sonia and we'll take it from there.
Great, thanks everyone. I think we can go to the next slide. So I think reiterating what we shared last time, we have about 2 million people total who we think are subject to the work requirements when we start implementing it. And there are various exemptions that we've all talked about in detail, but I think the point that we want to emphasize is that we think the majority of folks are going to have to verify their work. And so what we talked about last time is how we're actually approaching this. One is, even if we had sort of infinite resources, we would not be able to do all of this manual verification. It just would not work. So we're focusing on shoring up the data sources, the trusted data sources we currently have, which include federal data sources such as the IRS. We're working on improving our state data sources. So we currently use the Department of Taxation and Finance. We're also working on our connection with OTDA. And lastly, what we want to spend time talking about today is a new third-party data source that we are adding for income. So again, the purpose of all this work is we would really like to increase the number of folks who we are verifying automatically so we can reduce manual processing on the back end. So you can go to the next slide. So on this journey to find the data source that we wanted to use, we were really focused on looking at who our current data sources don't capture as well. And so those include often self-employed individuals, gig economy workers. Those are folks that we know, and many of you all know and have flagged for us, have a lot of trouble verifying their income with us. So in looking at the products available on the market, we looked at a number. We have decided to go with Truve, which when I pass it along to Stephanie and team, will explain how exactly the tool works. It's a consent-based verification tool. And a lot of the work that we're doing now with Code for America and that is thanks to the philanthropic support of a number of organizations who I know are on the call today, is that as we enter this new phase where folks are going to have to verify information they haven't had to provide before, they're using a new data source that they're unfamiliar with, we really want to focus on building consumer trust as we enter this new phase. We also want to make sure the tool is actually working the way we want it to and the way that it's supposed to. So we have partnered with Code for America to help advance that work. So we're starting what we're calling user research or pilot at the end of this summer to test how users are actually working with the new tool so we can fine-tune it as much as possible going into the full rollout in January. So with that, I will pass it to Stephanie.
Good afternoon now. I'm Stephanie Puglisi. I'm an Associate Program Director at Code for America.
Hey folks, I'm Minya. I'm a Design Manager at Service Center at Code for America.
And we're so excited to be working with Sonia and team on the, okay. Well, basically I'm Stephanie.
And I'm Minya.
Exactly. And we're from Code for America. And we'll tell you more about Code for America in a moment, but first really wanted to dive deeper into what is consent-based verification, as Sonia mentioned. So we know from existing research from the Department of Health that income verification is one of the highest friction points in the eligibility journey. So consent-based verification offers a promising alternative to manual document submission by asking a client to share their income information directly. And as Sonia mentioned, Truve was selected by the Department of Health as that tool earlier this year. So at its best, Truve and tools like Truve will significantly reduce the documentation burden and streamline automated renewals. This will help clients as well as assisters. However, that member adoption really relies on three key things: clear consent, inherent in the name of consent-based verification, a trustworthy experience, Sonia mentioned, we'll kind of double click into in a moment, and a seamless user flow. So really building that into the design of the existing system. We also recognize that assisters will play a huge role in guiding users through this process successfully. I will pass it to Menu.
Awesome. So one of the things we wanted to really make sure was true as part of the Truve pilot and rollout is that it really works for the people that it's intending to support, the consumers. And so the pilot is designed to be this period where we really look at that and try to learn from consumers and assisters about how it's working, how it can be improved, showing them ideas, getting their thoughts, and incorporating that for the full scale rollout. So the Truve pilot's kicking off next month on July 23rd, and we'll wrap at the end of December, giving us about 5 months to really take a look at how New York consumers and applicants are using this and how it can be improved. And we're really using this pilot period to make sure it's as successful as possible and fine-tuning any improvements before we do that full-scale rollout ahead of January 1st. So we'll break down in a moment how we're looking at the evaluation across those 5 months. Then I'll pass it off to Stephanie to talk a little bit about our organization, Code for America, who's the evaluation partner on this pilot.
Absolutely. So we're a 501c3 civic tech organization, a nonprofit. We believe services can be simple, accessible, and easy to use, even in government. We believe that outcomes can be measurably better and that we can serve everyone with respect and dignity. And I know that we really share these values with the New York State folks and all of you here. So what are we doing? We are co-designing with core stakeholders, and we really have bucketed those individuals and groups into 3 categories. We have direct users, so we are asking New Yorkers directly and members directly what they want to see, how they're experiencing the technology, and what would make them compelled to use it or turned off by it. We're working with internal leadership. So we have a coordinated group of cross-team internal Department of Health champions serving as our steering committee. And this will really allow us to move quickly throughout the pilot. So as Minya mentioned, this is only 5 months. That's really fast for technology, again, especially in government. And this group really is committed to helping make this user research period successful so that the full rollout starting in January will be seamless. And then we also are really relying on frontline support. So we have a strong reliance on assisters to support the technology. Again, we know that such a high percentage of New Yorkers work through assisters for this, and we really need them to trust this technology in order to recommend it to their consumers. And we'll also be using data as a feedback loop. So the quantitative data will tell us where people are entering or dropping off or even succeeding in the Truve flow as we kick it off. And we'll be able to see, you can imagine graphs as far as where seems to be a point where folks give up on the technology, right? We've all been there. I do that all the time. I start a process and I say, I don't want to do this anymore, and I X out. So we are working with Truve as well as Department of Health to get access to that data very quickly so that then we can follow up in a qualitative sense and ask these individuals directly, what caused you to stop using it? What did you decide to do instead? Did you want to go to a manual upload and really understand? So that qualitative research will tell us why. why we're seeing the data the way we are. And together, that will help us improve the pilot in real time and understand which groups are benefiting or struggling from it, especially the groups that Sonia mentioned around gig workers, self-employed, and folks with multiple streams of income. And then we'll be able to make evidence-based recommendations about how the Department of Health should scale. Back to Minya.
Stephanie, next slide, please. So to prepare for the pilot, we've already started to do some of that listening and learning with key stakeholder groups to get a sense for how truth might land before the pilot even begins. And as Stephanie mentioned, we're really, cognizant of how assisters and navigators are a critical support in rolling out this technology and a critical support for applicants across New York. So back in April, we spent some time with 4 community-based organizations across Albany, Brooklyn, and Queens who assist with applicants to get their thoughts on what would be important to keep in mind for how Truve was designed. So we spent that time shadowing assisters to understand how they work with consumers right now, to see how income verification is currently done as part of an appointment. And then we showed them mock-ups or drafts of the new Truve experience, including that website page that transitions from NYSO to Truve and the pages within Truve that applicants go to connect their income sources. And we listened to their perspectives on whether that was understandable, whether they foresee any risks, and what they thought could help improve communications. And so what we learned was, wonderfully, assisters were really positive about the Truve opportunity. They expected this to help, especially younger folks with higher digital literacy skills, but also those working for large employers. They felt the promise of Truve looking at it. Assisters also felt it was really important to equip their staff with training for diverse customer use cases and operational guidance. How is this going to work? What does that link look like that's going to be sent to folks, as well as having an FAQ support for consumers who are using the tool. And they gave us some practical feedback on specific messaging and design, emphasizing that, really, as Sonia mentioned, member adoption is really going to come down to trust. And so those are lessons that we've incorporated into the Truve design for the pilot. Next slide, please. We also spent some time talking to consumers. We did 2 rounds of research with consumers around specific proposed language. We spoke to 10 Medicaid eligible consumers living in New York in that process. So we showed them different versions of the text message they would receive, inviting them to use Truve, 2 different pages of the NYSO landing page that would transition them to Truve, as well as the landing pages within Truve. Similar to assister feedback, our goal was to understand from consumers, is this understandable? Is there wording that could help you, feel that this is really trustworthy? And broadly, what would make this an easier thing for them to want to adopt? And some highlights of things that we learned is that folks really, leaned on the NYSO branding to be an indicator of trust. So seeing things like the logo really made a difference. And the best pattern to use in building trust is not simply more information, but just using cues that help establish legitimacy, clarify the action that's needed, present choices and their benefits, and reduce the uncertainty of engaging with this new thing. So phrases like safe, private, encrypted, optional, along with proof points like, this Truve service has been trusted by 100,000 plus applicants, which is true, helped some participants feel more comfortable enough to continue using it. So again, all lessons that we've adopted into the launch of the pilot. I'm gonna pass it back to Stephanie to talk about our evaluation.
Next slide, please. So as we keep telling you, this pilot window is a really crucial step in advance of the January 2027 deadline for work requirements. And it really offers the opportunity to learn directly from, again, New Yorkers themselves as they start to experience this technology, as well as assisters, and then on the back end from the Department of Health staff as well. Are they seeing documents come through that meet the needs for income verification? If not, how do we tweak that? Again, what's the reliability of this technology as well? And we also will be working with individuals who staff the call center so that we can understand, again, where are people getting tripped up potentially? Are they calling the call center to ask about it? Do they have reduced calls? Dare we hope for that? And then also how that tool will impact the kind of workload as a whole, again, in advance of these increased work requirements. So across the 5-month pilot, we plan to break down our evaluation into 3 different phases and then learn and incorporate those findings into the concurrent phase. So phase 1 is roughly the first month of the pilot. So it kicks off January 23rd. And we're thinking that first phase will go through August. We want to learn quickly and again, iterate into the next phase. So we're calling that first phase first impressions. And the focus is monitoring on early usage. So are we seeing folks, flood to Truve and really use that technology? Pulling top line metrics, like what percent of people who are sent a link to engage with Truve actually use it and which don't. Where people are dropping off in the flow, again, do they make it to a certain point and decide this is too much work and quit? Or are they making it the whole way through? And again, what percentage are completing this? We'll also reach out to that call center staff, assisters, and New Yorkers to get direct reports of feedback. And then using that first phase, we'll go into phase 2, which we're calling deep dives. So we'll analyze the data we got from phase 1 more holistically and at the end of that first phase to understand how to improve any struggles that we're seeing with Truve. So for example, if we see the data that lots of people who complete Truve have multiple jobs, or folks are duplicating work by submitting through Truve and then doing manual upload, we'll be able to reach out to those individuals and understand kind of why they felt the need to do that, or if they were asked to do that. And then we'll also focus our research on understanding their perspectives and how Truve could work better for those groups. We'll also want to focus kind of geographically and demographically in case there are certain populations that are responding more positively to Truve or not using it. We want to understand those as well. And then phase 3, we're looking at all of these findings together and really with an eye of how would we recommend that the Department of Health scale Truve again in advance of that January 2027 rollout. So this will also be where we focus on impact. So how will Truve save individuals as well as assisters and the state time, effort, and again, maybe money, and then consolidating those priority recommendations for future releases. So they will continue to improve on this experience as well, even after that January 2027 release. And with that, I will pass it back to Jason.
Okay, so before I hit the next button, we just want to recap. We're adding this data source to smooth the process. We're keeping it simple. We're keeping it seamless. It's in our environment, and we're keeping it secure. And you will hear those words over and over. We do have a lot of questions in the chat about Truve. I think this video will help explain what it looks like. Again, this is where we are in the pilot phase, and it will give you a sense of the consumer journey. Once we get to full-scale rollout, there will be some differences, but for now, this is really where we are focused. So with that,
and I'll make just one point that I should have said up front is that we're using this as an income verification tool for all programs, because we know that across all programs, people have to verify their income. So while it helps us come into compliance for Medicaid work requirements, the way that we're rolling this out is across the board, across all programs.
Yeah, and that's a good point, and that really ties to, the marketplace is becoming a bigger, in a sense, marketplace for more members who are impacted. So with that, let's look at Truve.
New York State of Health trusts Truve to help members quickly and safely share their household income. Here's how the income verification process works. When a member needs to verify their income, they will receive an email or text from New York State of Health with a unique Truve link. Clicking the link takes the member to Truve, where they can opt in to connect one or more payroll accounts. members click Agree and Verify to get started. After that, members are given the option to search for their employer. The list in Truve is pre-populated with larger employers. Here, we'll select Home Depot. A member employed with Home Depot would log into their payroll account directly through Truve. Once connected, Truve verifies information and displays a success message. On the review page, members can see the data that was accessed: income, employer, and pay frequency. Members can either verify and submit the data or report an issue without submitting. Finally, Truve confirms if a member completed their submission. Then, New York State of Health notifies the member through existing communication channels that their verification is complete. Truve is a simple, secure, and seamless way to verify members' income and keep their coverage active.
Let's just pause for a sec. We have some questions in the chat that the video volume wasn't audible. Is there a way to turn it up?
Oh, yes, there is.
Okay, let's.
We could play, can we play it one more time?
Yeah, let's do it one more time.
Okay.
One more time.
Okay, we're gonna try.
New York State of Health trusts Truve to help members quickly and safely share their household income. Here's how the income verification process works. When a member needs to verify their income, they will receive an email or text from New York State of Health with a unique Truve link. Clicking the link takes the member to Truve, where they can opt in to connect one or more payroll accounts. Members click Agree and Verify to get started. After that, members are given the option to search for their employer. The list in Truve is pre-populated with larger employers. Here, we'll select Home Depot. A member employed with Home Depot would log into their payroll account directly through Truve. Once connected, Truve verifies information and displays a success message. On the review page, members can see the data that was accessed: income, employer, and pay frequency. Members can either verify and submit the data or report an issue without submitting. Finally, Truve confirms if a member completed their submission. Then, New York State of Health notifies the member through existing communication channels that their verification is complete. Truve is a simple, secure, and seamless way to verify members' income and keep their coverage active.
All right. Do we want to just talk a little bit more about Truve and some of the questions that are in the chat? How are we dealing with folks who may not have access to a computer, or what about gig workers? And some of that, we're developing right now. Maybe kind of talk about how we're trying to understand through our research, like how to approach those particular situations.
Yeah. One of the things I do appreciate about the way that Truve is designed right now is that it is mobile first. And so thinking about all the folks that are gig employees that are using their phone to do their gig work, it's the same kind of interface that they would be interacting with. I find the Truve interface actually is quite intuitive once folks are able to just sort of identify their employer in the search function. It gives them multiple options for how to log in depending on what the employer is. So it's trying to be as consumer friendly as possible for those who have access to a mobile phone.
I think another key here too, thank you, is again that assister population. We know that 80% of applicants go through assisters, and so what we're already working with the state around is training for those assisters so that they're comfortable and confident in that technology, because we know they will get questions about this. This is a new kind of aspect to the experience, and so really wanting to lean on the frontline workers who are interfacing with members and applicants there too. I think that's going to be critical.
We have Sonia, do you want to just go back and forth with a couple of questions?
Sure.
Okay. So here's an interesting question. Is the consent ongoing, or limited to each renewal, presumably in True? What does it mean for the member if they select reported issues? So that is sort of a two-part question. I think the second part is the customer service side of the coin. But it seems like the first question is, when you consent to True, do you have to continue to reconsent at renewal?
Do you want to take that or should I?
If you can, I can add color.
Yeah, I think it depends, right? Because I think that if your credentials change, for example, if you change the way you log in, you will have to consent again. I think there are also some limits depending on the employer, how long that consent is valid. I don't know off the top of my head, like what the variance lengths are. We can follow up with that information, but I think sort of depends how they're providing consent. Anything else to add?
I think that's correct. And I think the other part is this is intended to help with automated renewal. And so there's a balance of consenting upfront for the renewal that someone is facing. And also then not giving open access for, anyone to continue pinging the Truve instance or pinging that account without their consent. So I think that's a little bit where we are in this journey of finding that balance and really working with, the privacy experts and folks at Truve who have rolled this out in other states and in other instances, as well as with New York State, to ensure that we're hitting that balance just right. But I agree. I think we can follow up with further details.
Sounds good. Lots of questions around self-employed or folks who work for small businesses. Can we talk a little bit about that to the extent that we can in our journey on this one?
Yeah, so I would say it's not a 100% data source. Like, I think when we originally talked that Truve has the capability of connecting to payroll providers, it also has the ability to connect to banking institutions. We have in our research found that sometimes when people have trust issues, when they start seeing their banking institutions show up as an option. So I think we are exploring what it would look like to onboard that source as well. I don't think we're going to start out including banking institutions because of that trust issue, but I think with our user research and as we understand the tool better, that will definitely help, I think, self-employed folks. So it might not be for when we launch, but I think that is something we are exploring as an option. Anything to add to that?
I think the only thing I would add to that is that there's also an option within Truve to manually submit documents as well. So if folks don't find their employer, but they know that they have the documentation to demonstrate their income from the last 4 weeks from their employer, they are able to use Truve and submit that documentation manually as well. So both things are true. We're looking into, whether it makes sense to integrate that functionality to connect with banks that would support people with self-employed income and other sources of income. And folks can, in the interim, submit manually.
And we have, to the extent we have access to data and some of the top employers that we see individuals submitting, we are sort of testing those in advance with Truve to make sure for individuals who are going to try to access their income for those particular employers that information will be available.
Sounds good. I guess the other half of that question talked about customer service. How will problems be addressed? That's an important piece of this because we do want to make sure that as we're building trust, we're solving problems and people know that they can come to us. So to the extent that we can, if a person has an issue with that, how are we approaching that? How are we handling that?
I can start. So we are working directly with the folks in the call center and also in the back office who are then processing the Truve documents and truly verifying that income beyond the true submission. And so from the call center side of things, we again are working really closely with Truve as well as the call center team to make sure that they have similar but more tailored trainings and then guides around the Truve technology. So kind of same thing as the assisters. We want to make sure that the call center is also really well equipped to answer these questions, troubleshoot. There is only so much they'll be able to do because they will not have direct access to that Truve instance due to security reasons. And so they'll be able to walk someone through the steps and again have a kind of a troubleshooting guide. And from there, we expect that most issues should be solved. If we're seeing a bigger issue there, that's again where these quick learnings and iterations will come into play because we'll be able to work with Truve as well as with the state and the call center to understand, hey, this is a real pain point that we're hearing over and over from consumers that's stopping them from using Truve or that's driving them toward the manual option. So that real-time feedback, I think, is really critical for the call center folks.
And I think there was another question about if you're having trouble logging in. I think it's similar to when any of us have trouble logging in, like you can actually go and click forgot your password and sort of work through that flow that sort of we're used to. And I think Truve sort of waits for you to resolve that. And then you can pick up where you left off and continue the verification process. We did get a question about what happens if you click the report an issue, like if you're seeing an income that's not correct. I have seen that screen before. I don't remember exactly what it looks like, but I think you're able to say like, that's not right anymore. I'm not working there, or the amount is incorrect. Do you all remember off the top of your head all the options for how you can?
Not off the top of my head. I think also we decided for the pilot, we would try it without showing folks the income summary page. The rationale being that we weren't certain exactly how we wanted to handle situations where people felt like the income was discrepant that was reported on it. So we wanted to do some further testing on that. So it won't be rolled out in the pilot, but it's something we definitely want to investigate for full scale rollout.
And I'm sure as many of our sisters know that consumers sometimes when you present their income to them, especially modified adjusted gross income, it's not necessarily what they think their income is. So I think we are trying to be really thoughtful about how we display that information.
Yeah.
And just last question, I think there's a thread about this on, who are the employers in Truve? What about self-reporting or like apps like Venmo, PayPal, Cash App? Maybe for, I think, 2.0 version, those options will be available. But for the pilot, right now, it's more of a focus on your employer and your payroll.
Exactly.
Okay.
Yeah.
So, this, I think, as we're talking about this is really, income verification 1.0. We want to make sure that we're learning as much as possible about it. And though, there are other options for people to submit documents, I like to characterize this as this is our direct deposit moment. Like we're trying to move people into automation because as we learned from this morning, that's where the policy seems to be pushing us. So this is not only a way to address the what HR1 is telling us to do, but it's also a way to really enhance New York State of Health overall for everybody eventually.
And I know none of our sisters are shy about sharing feedback, but I think like especially through this pilot period, we would like your feedback on how we can achieve. I don't remember all of the letters, but
Don't worry,
building trust and increasing adoption. Because again, falling back on manual verification is just very unrealistic. We don't want that to be the primary path for our members here.
All right, so I'm just going to forge ahead.
Yeah.
Okay. So the second half of the day has really been about, the customer journey. We've talked about the Truve income verification tool, how we are going to really try to listen to consumers to see what they think, how we'll apply this. So on the comms and marketing front, we have been very busy since our last convening. And so just as a recap, at the last convening, we talked about the phases of our marketing and communications campaign. So phase one was awareness and generating awareness with partners, stakeholders, generating awareness, internally that this thing was happening, and really started to try to figure out how to educate folks on why it matters. Phase two was preparation. We're still in that phase, but we are moving very quickly into the support phase. But with preparation, that means, developing our messaging strategy, figuring out what our partners need from us, setting up the tools and resources that are going to be easily accessible. And so as we move forward into Q3, Q4, that's really about, the execution of our messaging and making sure that we're continuing to build educational and administrative support for members and speaking as broadly and loudly as possible. And so with that, we have developed our campaign moniker, which is Stay Covered. This will be a branded campaign. We want this visual to reassure people that we are doing everything to help Medicaid members navigate HR 1. We want them to know that they have a trusted partner in us, and that all of our materials reflect what we've said, this simple, seamless, and secure approach to our messaging. So the way we've been looking at this is, there is a broad brand message, and I like to say that in the sense of building member trust and allaying fears of navigating these changes, making sure our members feel supported. This is a wonderful opportunity for the marketplace to kind of reassert itself as a trusted brand, and leverage the equity that we've built up with our consumers over the years, so that when we say, this is what you need to do, folks really listen to us and they believe in it and they know that this is coming from a secure place. The other side of this, which is the income verification tool, is we're making what is essentially a product enhancement to the application. So this is also, a part of our messaging. We want to maximize people's time in the application. We want to make sure that they have a seamless experience, because we are dealing with what was essentially 2 levels of consent. People need to opt in to, this new tool, and so they need to feel, that they're doing it within a trusted environment. So our challenge is to make sure that that brand message covers us in educating people on what the changes are, and then maximizing the consent and opt-in to the new tool. And as we, move from pilot to full-scale rollout, we want to make sure that, things are easy. We want to hear people, as we, do from our share your story comments. We want to hear positive stories about our customer service. We want to hear that, people were really nervous, but we helped them get through it. So that's, at a very high level, our campaign objectives. Again, to reiterate our North Stars, simple, seamless, secure. We are really behind that in everything that we do. One question that has come up frequently in the chat, and just in other things, is how are we casting a broad net, right? So since we last met, our comms and marketing teams, our research teams, everybody's been working to try to figure out what they need to do. So on the communication side, we've been developing our messaging. We have been looking at how we're going to execute, and I'll show that in a second. The other thing that I want to raise is we've been doing what I call a lot of friend raising, and our panelists here today are a demonstration of that. We have been, casting a wide net with community partners, other organizations, tapping into connections through our Medicaid social care network. Like, where are our friends going to be when we need them to start to talk about this? And that's been a very important part of our consideration, because it's not just making sure we're all talking about it, it's making sure we're all talking about it in the same way and in the same voice. So to that, we have really focused on creating toolkits, materials that can serve an assister who needs more detailed information, to a flyer like this one that says work requirements, they're happening, scan here. That's like a flyer that a street team can hand out at a parade, and just really start to cast that broad network. So when we talk about the campaign execution, I like to talk about this in two ways. There's high tech, which means we are leveraging all of our platforms: email, text, flyers. They may not seem so high tech, but they are still on this slide. Our website, our social media, all of our platforms, we want to activate, and we also want our friends to activate their platforms in the same manner. But I think, what is really critical about this campaign, if the slide will work with me, this campaign is also very high touch, right? We are dealing with, in many ways, a community who relies on other people to help them do what they need to do. At the last convening, we mentioned that 80% of Medicaid members use an assister to enroll. That is a huge high-touch opportunity. So we really want to make sure that our assisters are well-equipped to help folks navigate and to walk them through and really build that face-to-face rapport. Our call center, again, will be a critical group of people dealing with other folks as they call in. As I mentioned, our partner organizations will play a part. And then, going to where people go. We are going to be, in third quarter, summertime event season. That's a huge opportunity for us to get the word out broadly statewide. So that is really where we are on the communications front. We will start to, or continue to post information on our informational websites. We have we have two sites. We have Stay Connected, which is a general site where we talk about impacts on the marketplace side, i.e. Essential Plan and the QHP market. And we also have a distinct Stay Covered page, which deals with Medicaid issues. But they're all linked. Our no wrong door policy applies in this instance. If we can get people to New York State of Health and in the right place, they will find what they need. But we will start to ramp up with our communications July and August, starting to align with notices. So we know folks will be, receiving information. As we move forward, developing more materials and figuring out how to launch a full-scale campaign through, the end of the year. We are still looking at how we might be able to leverage some of our messaging during open enrollment, because that will happen November to December. And then we're also thinking about what does 2027 look like when we are in full scale rollout, and how can we, continue the messaging at that point, because that's going to be the critical time for a lot of people. So that's my portion. Do you guys want to look at the chat and maybe see if there are any questions?
I think we answered most of the questions that we're able to answer at this time.
Okay. All right. Well, with that, we are going to move into the last part of our day, and this builds on our friend raising. So we have some friends who are going to join us at the table, and we're going to talk to them about navigating change, moving from policy implementation to real world impact, a brief discussion on how organizations will support impacted populations. So give us a few minutes and we'll get set up. Thanks. Okay. Come on up, panelists. You guys need water? Sure. I should have it, but okay. All right. So we are here with our three panelists for today. Vanessa Beard-Streeter is the president and CEO of the Health and Welfare Council of Long Island. Welcome, Vanessa. Allison Hartman, I'm going to go in order of seating, is the Assistant Vice President, Revenue Cycle Services and Patient Access at New York City Health and Hospital. Welcome, Allison. And Kanchana Sagu, who is the Chief Impact Officer of United Way of New York City. Welcome. And I'm joined by my colleague, Bridget Harvey, who is one of our key members of the New York City outreach team. And Bridget focuses on making sure that we have lots of friends in lots of places to get the word out. So just a little bit on format. We have 3 questions that we developed for this conversation. And we want to kind of explore some different aspects of reaching people, measuring impact, and then also helping folks, transition to a new process. So with that, I'm going to turn it over to Bridget, and Bridget will be asking the questions, and we'll have a good conversation. Okay.
I'll start off with Vanessa.
Make sure, just make sure your mics are.
Just press this. You're on. Okay. Are you ready? Okay.
Yeah, good.
So much to what Jason has shared. Throughout today's discussion, we've talked about implementation, readiness, and the importance of understanding how policy changes are experienced at the community level. So my question for you is, as an organization working closely with underserved communities and community-based providers, how are you preparing for HR 1 implementation?
So thank you so much for allowing me to be part of the panel. I'm happy to serve with these lovely women that are here. I think from the standpoint of the organization, you want to ensure that you are arming yourself with the most up-to-date information so that you can be the best communicators of the information from New York State. So that means my healthcare access manager has to have all of the updated information, as well as all of our navigators and assistants. So I think that's the first piece, is like every time that there's an opportunity for a workshop, a training, a webinar, you need to be on all of them because you're not going to absorb all of the information at one time. So the opportunity to be on continual learning curves, I think, is extremely important. The second piece, though, is from the standpoint of the Health and Welfare Council, we are a convening organization for nonprofits on Long Island. So we have touch points with about 200 nonprofits on Long Island. So the Health and Welfare Council cannot be the only entity on Long Island that is talking about these changes that are going to be impacting our community. We also have to provide the information to our community-based partners so that they too are ambassadors of the information. So next week, we're actually having our first workshop. We're using the exact training and PowerPoint that was provided by New York State, but we're holding a convening for our community-based organizations so that we can continue to go through the information. And they need to hear it on a continual basis. It's not a one and done. So we start in June, July, we need to be meeting with them. August, we need to be meeting with them. September, we need to be meeting with them. And they may not have organizations where they have assisters or navigators, but they're serving the Medicaid population. So they are trusted and credible messengers within community that individuals will listen to. So I think that we have to arm all of our partners with the information that is needed because it's going to have to penetrate, deep penetration into our communities to ensure that the Medicaid members understand what the requirements are and that as a collective, we can help everyone help to complete and fulfill the new requirements that are being implemented.
Thank you so much. So from what I'm hearing is that you feel it's very important to bring awareness to your community-based organizations so that they're prepared to go out into the community.
Absolutely.
That's a great way to think and preparation. So I'm going to transition now to you, Conchana.
Bridget, can I ask a
Sure.
follow-up question?
Sure.
Talk a little bit about that, Vanessa, what you said in the context of populations for whom English isn't their first language. Like that presents like a whole other
Absolutely.
way. So what are your thoughts on those?
But I
that
also
sort of
think
thing?
the diversity of your community-based organizations is extremely important. So, you know, from the standpoint of our staff, we have bilingual staff that people feel comfortable because they can speak to individuals in their native language. But you have to ensure that that outreach that you're engaging in has to be with a diverse base of community-based organizations because some are going to be better credible messengers and trusted voices within community because of all of the fear that our communities are currently experiencing. So there are times where we may have a particular training that's for a subset of the community-based organizations so that we can nuance some of the issues that may not transcend all communities, but are particular to certain communities. So we engaged in that as it pertains to SNAP as well.
Mhm.
And so we had the fortunate opportunity to be SNAP enrollers, SNAP navigators. And so these work requirements went into effect as of March, really as of June, because it was a 3-month grace period. So we had the opportunity to kind of learn from our community-based organizations, what information do they need? We also needed to ensure that we had good, strong relationships with our local departments of social services, so that they know exactly what we're doing. They can rely on us. We know that our local departments of social services are strapped, right? Like they don't have the staff that they need to be able to fulfill the responsibilities. So it is incumbent upon us to help fill those gaps as well. And so I think from the standpoint of particular communities, and when you talk about English proficiency, you have to ensure that you're developing relationships with those community-based organizations so that they can ensure that there's far-reaching tentacle within those communities and those organizations to ensure that they too have the same messaging and can fulfill the same requirements.
So no one group has
No.
to do everything.
They can't.
It's about, and they can't.
You
No,
can't.
but they.
Right.
But the idea is, if you have connections,
Right.
then you can activate those connections,
Absolutely.
and then those connections can say, "Hey, we don't do this very well.
Right.
Let's have these folks do it."
Absolutely.
And really, that it just becomes this network.
Correct.
Okay. Yeah. All right.
Thank
Thanks.
you.
Thanks for that.
Thanks so much. So what I'm hearing is that the preparation really goes beyond the policy and what you're really sharing. So it's going to require organizations to understand the realities of communities that are what we're facing, and the appropriate support should be in place. So I'd like to segue to you, Conchana. As organizations prepare and communities begin navigating these changes, an important question becomes how we measure our efforts and understand whether our supports are really making a difference. So my question for you today is, what will be most critical in measuring our efforts to ensure communities feel supported, informed, and connected?
Thank you. Thanks for having me here today, and thank you so much for all the efforts that the state has been making. It's just much appreciated, and thank you to UHF for convening all of us today. So I work for United Way of New York City. United Way of New York City is an intermediary organization. Our strength is our community partnerships. So very similar to what Vanessa shared. We work with over 500 community-based organizations across the city. We are not the ones to directly serve New Yorkers who are going to be impacted by these policy changes, but we are conveners. We bring city and state agencies, philanthropy, and community-based organizations together so that we can equip CBOs with the tools, with the information, with the resources, so that they can navigate this increasingly complex benefits navigation space. So as an intermediary, when we think about measuring our efforts, the first thing that comes to mind for us is the readiness of our provider network. These are the CBOs that are seeing New Yorkers every day and are answering questions regarding the changes with SNAP, with Medicaid, et cetera. If the frontline organizations are not equipped, then they won't be able to support New Yorkers navigate these changes. So just recently, we conducted a survey of our network, and significant capacity challenges came up. A fourth of our network of the respondents actually had assisters. A third said that they are extremely unprepared. And this was earlier this year. A lot of information has been shared, and DSS has also done a lot of trainings, which we are really appreciative of. But I think the main point here is that our CBOs feel quite unprepared, many of them, to be able to navigate these challenges. And I think the trainings for the CACs are excellent, are great, but there are a lot of non-CAC CBOs that also require some sort of training, tools, materials that are easy to understand, and just a simplified version maybe. And then the second, in terms of measuring the efforts, do New Yorkers know where to go? Do they have the information? I think we've heard time and again that many New Yorkers don't even know that they are subject to these changes. They may miss the letters, they may not have a stable address. There are many situations that could prevent the information actually reaching those that impact, those who that it'll impact the most. So is there a way to kind of measure, do they know where to go? Do they have the information? Do they know which organizations to be connected to? And then the third, I think, which you all will be doing in terms of measuring our efforts is, are eligible New Yorkers able to maintain access? And how often will you all be tracking that data? It'll be great to share that back with the CBOs, especially if it's neighborhood-based or zip code-based, so that that information can be used to respond. So again, I think very similar to what Vanessa said, it has to be iterative, it has to be ongoing, it has to be continuous, and different organizations have different roles to play. But one thing is clear, CBOs are already strained and don't have the time to be able to interpret policy changes, the guidelines and the materials. They need information and dialogue on an ongoing basis.
So it sounds like for organizations that they don't have the resources that they need, like they're looking to us to interpret and lay out very clearly what these rules are. So it becomes a matter of saying, okay, I can rely on the state to make sure that I get the information that I need, so I'm not wasting my time and my resources trying to figure all of this stuff out. So it sounds like, the message from CBOs is, to us is we need your help interpreting and making sure the policy, like the steps, are clear, so that it's not just that we're talking to the members and what the Medicaid member has to do, but it's also the organization has to talk to the member. So they need to have that set of information.
Absolutely. So, for example, when the SNAP letters went out, which was last November, many of our CBOs started saying that they saw an increased volume in people walking through their doors, asking questions. For example, a 60-year-old coming in and asking, what does this mean for me? And trying to just understand what they need to submit, because there's new eligibility and that went into effect. We launched an initiative called the Community Benefits Resiliency Network, which is basically doing that. Our CBOs are looking to us to be able to coordinate and convene with partners like you all to be able to share that, those simple tools and materials with our network. So that's exactly right, Jason. We would love to continue that dialogue and hear more from you all.
Great. Yeah, I mean, I think the way you phrased it is this is the panel of intermediaries, like for different reasons. But it's really key for us to make sure that that level feels aware, up to speed, and then they know that we have the resources that they can use. So, okay. Bridget, you want to?
I just want to ask one question.
Yeah, you have a follow-up?
What would success look like if we got it all right? What would success look like in a year from now?
I think ongoing communication for us, it would be the ongoing communication with our network of CBOs. And again, this is not just the assisters, but the broader sector. Organizations like United Way and other United Ways can play that role in bringing the information from the network to the state. And this is more than quantitative data, right? There are stories, there is the human impact. And as an intermediary, we sit at that intersection of real stories and the data. And I think success would look like having that dialogue, hearing directly from the people who are serving New Yorkers and hearing about their experience. I think ongoing surveys and check-ins, the numbers that we saw in early February, we hope to see, not such low numbers in terms of preparedness. So those are some examples of things that I would say keeping that engagement and surveying organizations to make sure that they feel equipped would be important.
Yeah. I think I would just add on to that, one of the things that we in the marketplace, prior to the legislation being signed, we spent a lot of time talking about, okay, this is what we think is going to happen. This is what we think is going to happen. And then it happened. And then the next question was, okay, well, what are the results? What are the results? Like, what are you seeing? So I think part of it, from, okay, how has this impacted enrollment? How many people are dropping out? How many, people are losing coverage because of, they haven't paid the premium? Like, we need the data. And I think part of what the success measure will be is setting the expectation that the data is gonna flow in, but it's not gonna be immediate.
Right.
Like, we'll have some time to go to see, what the trends are, how people are reacting to it. So I think the other part of this is setting the expectation, and maybe we, maybe organizations, we have to think about, like, how are we gonna capture impact data? Like, are we even equipped to do that? And then when we're asked, because we're going to be asked, what's going on, do we have, either partners who can help us with that, or the infrastructure in place to say, okay, we're seeing this and this is the trend.
Yeah.
and so on and so forth. So really like setting that data reporting expectation, I think is a big part of it.
Absolutely. Definitely hearing some common themes. Want to segue now to you, Allison, and speak a little bit about your perception. So beyond measurement, successful implementation also requires trust. Communities must feel confident in navigating new processes and systems. So my question to you today is, our new income verification technology could raise some concerns around data and privacy. So how have you navigated processes and technology changes that raise concerns around these areas?
Well, first, I just wanted to reiterate what my other panelists shared, that I really appreciate being asked to join and participate in this really important conversation today. I think it goes without saying that the problems in front of us or the challenges that we're facing with these new rules are really immense. And we're not going to be able to really rise to that challenge without introducing new technology and new processes. As the city's public hospital system with a really robust infrastructure in place to assist our patient population with health insurance enrollment and other benefits enrollment, we know that we simply cannot absorb the impact of these changes without introducing new technologies. So in order to do that, it is really critical, I think, as many presenters mentioned today, to build that trust in new processes, which I think there's two angles to that. One is improving or, allowing for the community members and the individuals that we're serving to trust in the process. And the other is really making sure our staff, who are the ambassadors of the process, have a good understanding, are well educated, have the tools and the information to be able to reassure individuals who are participating in the new process, but also be transparent. And concerns around data sharing, I think, are real in some situations. So we really need to make sure that we're arming our staff with that information in order to really be able to provide that assistance to individuals, while we really being sensitive to those concerns. But technology, I think, is going to be critical to us being able to really rise to the challenge and, be able to serve more individuals when our resources are really strained.
I want to ask a few follow-up questions, particularly for Allison. So not just because you're talking, but two things. Like, do you think we're in a moment where what we're doing with Truve and the income verification tool, like, it's not so far away from what consumers do normally, on their phones, with data, with, automated systems. Do you think it's because it's dealing with healthcare that it just feels maybe a little bit more sensitive for folks?
Well, I think, as you said, I think we're all sort of getting used to technology playing a really core role in just our day-to-day lives. So folks, I think, do have familiarity with using very similar tools, and I think have demonstrated that, with the right support, they can engage with the tools and use them successfully. I do think that there are elements around, health insurance screening and enrollment where you are you're gathering particularly sensitive information. So there is some additional sensitivity there. But I do think that's where our navigators can really help our patients and community members navigate the process, provided that they feel comfortable. So I really think their comfort with the technology is the most important thing.
Right. And I mean, most people have smartphones, a lot of people, have jumped the home computer and everything is on their phone, which is good for us because New York State of Health is mobily designed. Mobile friendly. Thank you. Thank you, Sonia. And so this whole thing can happen, right there, and maybe with somebody guiding them through that process, so it's not so scary. I do
I do think, though, that when you are using this system where it can ensure that you have access or you don't has a level of anxiety and angst around it. I think our populations are becoming more digitally savvy, yes, and using our smartphones and accessing and putting in information, so forth and so on. But when you're talking about putting in information that is going to make a determination as to whether you have access to healthcare or not,
Right.
I
That's the
think
part.
that's the
Yeah.
environment that creates that angst and that anxiety, and people are very concerned and a heightened concern around that
Right.
type of environment.
Right. Because what happens if,
Right.
Right.
Or
So
I don't see my employer on here.
what do I do? What do I do? Or if when we look at when you look at folks moving through websites and you get to a part where you're like, I uploaded it and I'm clicking on it. Why isn't it working? Like that sort of, that's the technology piece, but there's real like human fear behind that. Yeah, no, that's a really good point. The other thing that I wanted, Allison, when we talk about intermediaries, I mean, New York City Health and Hospitals, that's huge. That is, a hospital in every community across the city, big ones and small. Do you want to talk a little bit about how maybe that fits in with building out this network to reach people?
Yeah, so I think as you mentioned, I mean, our patients really are really representative of the individuals who are going to be most impacted by these changes. And so, I think the way that I'm thinking about it is we can almost turn that into a positive. We already have touch points with a large segment of the population who's going to be impacted by these changes. And we can be a conduit for information, raising awareness, I think, as you were speaking about, just in terms of the communications effort, really, echoing some of that messaging and making sure that it is reaching the right communities and the right individuals. But I think also leveraging our role as a trusted healthcare provider and also leveraging the relationships that we have with community-based organizations as well to be that trusted face to share the message, to help reach, the individuals most impacted, which I think, we've already been looking to do given some of the changes that are afoot today and are definitely going to look to do with some of the upcoming changes.
Great.
Before we close out, I didn't know if there were any questions in the chat that you wanted to.
Then we can move to.
Okay, just to further highlight, one of the key themes that you shared and what I heard a lot today was trust, bringing awareness, and also collaborating in the community. So as this theme being discussed today, being trust, whether we're introducing new processes, new systems, or new requirements, trust really remains central to this successful implementation. So I just have a question before we close. I'd like to know from the panel if there is one factor that you feel that would make, that you'd like to leave or share with the audience today in regards to the implementation, whether it be the focus on trust, networking, or in your education and awareness, in your sense, what would it be?
Sorry. I think it goes back to building the capacity of those who are closest to the people who are going to be impacted by these policies. Ongoing communication. This is something that's here to stay for a long time. So really that sustained investment in partnerships. And I think the ongoing communication and working together is what is going to be important over the next implementation period and beyond that. Right now, I think information is most important. And as we hear more, we want to share more of that.
Allison?
Yeah, and I mean, I think I would echo what Kanchana was mentioning, but also just say, conversations like the one that we're having today, where, organizations, providers, health plans, others who, really have direct experience assisting individuals who are going to be impacted by the changes, who have really been the boots on the ground to really be able to, gain that information, as policies and workflows are being developed, but be able to really offer, meaningful input as folks who have a lot of experience.
I guess I'm going to move a little bit from what you said because you've already said it, so I don't need to say it again. But I also think we have to look at the other ways that people are fulfilling these requirements. So we are talking about working, but then there's also opportunity for workforce development, job training, there's volunteer hours. And I think from the community-based standpoint, we need to be coalescing and pulling those opportunities together and resources together so that individuals are going to have one place that they can go to see what are the workforce development opportunities that exist, what are the job training and upskilling opportunities that exist, what are the volunteer opportunities that exist, because we talked about earlier in the panel discussion that you may be able to meet it with a portion of the dollar amount that's associated with you working, but you're going to have to fulfill it with either training, education, volunteer. And so we need to be amassing those opportunities. It's difficult. We know the systems are complex. We want to remove the barriers as much as possible. It's hard to know that there's a workforce development opportunity that's, on 42nd Street in the city, because you have to know how to find it. So if you create the platforms that exist where it's all in one place, and it may not be exhaustive, but at least it's an initial list that people can access so that they know I can participate in this program. This is going to keep me connected to the benefit. Even though I may not currently have employment, I'm going to be able to remain connected to this benefit, which is foundational to me being able to exist as a human.
Yeah. Really good point. And maybe that's the first job for the community-based organizations. Like, we can focus on this side and you guys start thinking about this on your side, and we'll come back and figure things out. Wonderful. Well, thank you to our panelists. Thank you to all of our participants. Amir just let me know that he had to attend to some other business, so I am going to wrap for us. Again, thanks for coming to our convening. In terms of next steps, we are just moving forward to continue to interpret policy, put our plans in place, and work with our community partners and intermediaries to make sure that this works. So, do you want to?
Yep, I would love to have a few closing remarks. I want to thank you all for participating in this second convening on HR 1 implementation plans. I think that we have all heard a lot of what has been taking place between the last time that we met and today. And I want to just give my deepest thanks to our partners at the state for all that you do and are doing and will be doing. We heard a lot about infrastructure development, and infrastructure, as we know, is dependent on data, technology, but it's also, most importantly, dependent on relationships. And we just hosted a convening yesterday where the keynote speaker said something that has stayed with me and will stay with me, I think, for the rest of my professional career, that I want to share with you all. And then you kind of sit with it, and I'm sure it's going to stick with you. And she said that infrastructure is love at scale. Let that sink in, right? Infrastructure is love at scale. And I think what we are hearing is really the depth of caring that we have at all levels of the state to ensure that we maximize the number of New Yorkers that stay covered, and the importance of ensuring that we all play a role, and the clarity that there needs to be in terms of us taking direction from the state and then running with that. And so I hope that sinks in, because it's certainly something that I've been sitting with, and that gives different meaning to what it is that we're trying to do collectively as New Yorkers. So with that, again, I want to give my special thanks to our partners at the state. I want to give Special thanks to the folks here at UHF that made today possible. And I want to give a special shout out to say, I hope that we will see many of you on July the 30th at our annual Medicaid conference. In-person tickets are nearly sold out, so act fast, or you can join us virtually. We will be at City Winery this year. Additional details and registration can be found at our website, uhfnyc.org. I think the biggest draw every year is Amir's keynote, so we look forward to that. And then the last thing I want to say is to wish all of you fathers in the room, in person, virtually, and elsewhere, a happy Father's Day, and also to those of you who may not yet be fathers, but are father figures, just as important. So thank you all.
Thank you.
Thank you. Thank you, ladies.